Now the insulin. So as I told you that insulin is a polypeptide, it's a protein hormone consisting of the two chains, A chain and the B chain. So A chain with the 21 amino acids and B chain with the 30 amino acids. For that again they got the one Nobel Prize. And see the numbers. These are glycoproteins, GL1 glycine, valine, glucine, cysteine, okay, 309, lysine, proline, so etc. etc. They given the different numbers and the different names of these cells. So what happens in our designer insulins are, when you have you heard of the Novorapid, Aspart, Glucine, okay, so they are the very rapid acting insulins. You need not wait for 20 minutes or 30 minutes before the food, like your Atrapids or your hum insulin Rs. Okay, so these your regular insulins, they are in the hexomeric form. So they have to be converted to the monomeric form for its therapeutic action. So that is the reason you have to give at least 30 to 40 minutes prior to the food. What the regular insulins you often use in your general hospitals, your Atrapids or insulin Rs are 30/70. So don't give injection and then immediately ask the patient to take the food. You have to wait for that conversion, for the therapeutic action to control it. These insulins, the designer insulins or analog insulins, they are in the monoperic form. So they start immediately action. So within the 5 minutes, they start action. So that is the reason your control will be very good with these designer insulins or rapid acting insulins. Insulin is secreted from the beta cells of the pancreatic islets. They constitute 60% of the adult cells. So remaining 40% is the alpha cells and the delta cells. So along with the insulin, C-peptide and the amylin are also secreted. So the C-peptide is very important. It is very difficult to get the insulin levels in the lab. So the insulin is very labile one. So the values change very dramatically. Whereas C-peptide is a tough one. You will get the very good results for the C-peptide. So to know whether in your body insulin is producing in a good amount or not, we are getting the C-peptide levels. Because for every given one insulin molecule, you are having one C-peptide. Okay. So if you calculate the C-peptide, suppose C-peptide is 10. How many insulin molecules are having? 10. So in that way, we get the C-peptide, and if the C-peptide is very high, so what is the type of the diabetes? Type 2 diabetes, that is hyperinsulinemia. Suppose C-peptide levels are very low. So very low means insulin is also very low. So that means it is type 1 diabetes. So when you are in a doubt, see that child now, 12-year-old child, I get it now. I get the C-peptide, it is very high. I get the GAD65 antibodies, they are negative. So that means it is type 2 diabetes. If it is type 1 diabetes, C-peptide levels will be very low and GAD65 antibodies will be positive. That means autoimmune destruction of the beta cells by the antibodies. So this is the biosynthesis. First is the pre-proinsulin, then the proinsulin, and then the insulin, and insulin plus C-peptide. So what are the initiators of the insulin secretion? So which stimulates what stimulates the insulin production? So your glucose will stimulate certain amino acids like leucine, lysine, arginine, and the fatty acids. So they stimulate in your body to produce more and more insulin. Suppose if you are taking the more glucose, more rice, more wheat, more sweets, so what happens to your insulin levels? They will go because they stimulate. Suppose you are taking more fat, so what happens to your insulin levels? Again, they will go. See the fatty acids, they also stimulate the pancreas to release more and more insulin. So you will have more and more hyperinsulinemia. Potentiators of the insulin secretion amplifies the insulin release only in the presence of the initiators. Your glucagon, other amino acids, acetylcholine, GLP, GIP, adiponectin. So these are all the important. So glucagon is antagonist to the insulin. So the more the insulin, the glucagon suppression will be there. So glucagon is causes hepatic glucose overproduction. What is adiponectin? Adiponectin. So that is released from your fat cells. So unfortunately we are having the low adiponectin levels in Indian population. So that is again another reason for our more vascular deaths in our Indian population. Adiponectin is protective, but we are having low adiponectin levels. How to improve the adiponectin levels? Physical activity. Physical activity increases the adiponectin levels. What is the good lipids in our body? So are they higher or lower in Indian population? Low. Again another cause for our more and more vascular deaths. So Indians are having the more vascular deaths for some reasons, and one reason is HDL low, and then adiponectin levels also at a lower level. So this is the glucose stimulated insulin secretion. So when your diet contains more and more carbohydrates, carbohydrates nothing but your glucose. Again this glucose goes to the pancreas. Which cell? Beta cell or alpha cell? Beta cell. So in the beta cell, at the what is that name? Security guard. So his name is glucose enters into the entry of the glucose into the beta cell via GLUT2. So GLUT2 receptors are there. So that glucose will enter into the beta cell, and in the beta cell it gets activated because of the more and more glucose. So that is by the glucokinase enzyme. Okay. So after your glucose entry into the cell contains more and more ATP. So more ATP means more energy. So the binding of the ATP to the potassium ATP channels and closure of the channels leading to the membrane depolarization. So after your ATP charging, so you have the two types of the channels in the beta cell, potassium channels and calcium channels. So the potassium channels will close and calcium channels will open. So once the calcium channels open means what are all the formed insulin is there that will be released into the portal circulation. So that is how your glucose will stimulate to release more and more insulin. Okay. So whatever the glucose is there, excess glucose there in our body, so this glucose will go to the beta cells through the GLUT2 receptors, and then activation of the glucose by this enzyme, that is a glucokinase enzyme, and your beta cells will get more of energy, that is your ATP. So more energized ATP will make your potassium channels to close and calcium channels to open, and then once the calcium channels open, what are all the formed insulin is there in your beta cell, so that will be released into the circulation. And then what will happen to the insulin levels, to your glucose levels? Insulin will reduce the glucose. So that is our physiology. So when I am having the glucose in my body, so that my glucose will go to the beta cells and make the insulin to release, and this insulin will make my higher glucose levels to make him euglycemia. So at any given time, a normoglycemic individuals, the blood sugars will be normal. So this is the normal physiology. Okay. So what happens in your type 2 diabetic individuals? That insulin entry will be less. So that lowered insulin levels is not sufficient to control your blood sugars. See the glucose stimulated insulin secretion. So you have the two phases, phase 1 and phase 2. So in the phase 1, what are all the formed glucose is there, insulin is there, that will be released immediately. So that will be more. In the second phase, a slow and sustained insulin release. Suppose you have the postprandial hyperglycemia after food. Okay. Suppose you have the phase 1 here. Which one is good or not? Phase 1. Insulin release is more. Suppose if you have the good phase 1, so what will happen to your postprandial blood sugars? Come down. So what happens in type 2 diabetes? Postprandial hyperglycemia is there or not? Yes. Why? Because phase 1 of the insulin release is lost. Okay. So insulin is having the two actions. One is the phase 1 and the phase 2. And the phase 1 defective insulin action, So what makes your blood sugar levels will go up? That is postprandial hyperglycemia. Am I clear? So the diabetes also will have the random blood glucose is there or not? Random blood sugar also will be higher, no? Why? Because of the second phase is blunted. So in the second phase, you are supposed to have that much of the insulin, but in diabetic individuals, that much of the insulin release will not be there. So blunting of the second phase will make you a random blood sugars at a higher level, and absence of the first phase will make you postprandial hyperglycemia. Am I clear? So this is the insulin actions in the liver. Insulin stimulates the glycogen synthesis. What is glycogen? Stored form of the glucose. Suppose you are taking the 4 idlis. Suppose your body needs only 3 idlis. So what happen in the extra idli glucose? So that goes to the liver in the form of glycogen. So again glycogen will be converted to the glucose. Suppose today you are supposed to take the lunch. Usually you take at the lunch at about 12 noon or maybe 1 p.m. Suppose delayed by half an hour or 1 hour. So you need glucose. Okay. So that glucose where you are going to get? From the glycogen. What are all the stored glucose is there in the liver? Not only in the liver, that also in the muscle. Glycogen is stored in the liver as well as the muscle in the form of the glycogen. When you are fasting for a few hours, this glycogen will be converted to the glucose. That is called glycogenolysis. So when you are having the insulin, so insulin inhibits glycogenolysis. Insulin inhibits neoglucogenesis. More and more glucose production. So you are having more amino acids, you are having more fatty acids. These also will be converted to the glucose by means of neoglucogenesis. Neoglucogenesis means getting the glucose in the liver not from your glycogen but from your amino acids and the fatty acids. Suppose you are supposed to take the lunch at 1 p.m. You have not taken till the 6 p.m. So what are all the glycogen is there in the liver and in the muscle is exhausted. Then what happens to the, how you survive without glucose? Then liver takes up the proteins and the fats. You are all having a lot of the fat. Okay. 90% of us are having very good number of the fat cells. So the liver stimulates your fat cells to go to the liver, and in the liver again converting back to the glucose. So that is called neoglucogenesis. So getting the glucose not from the glycogen but from the amino acids and the fat cells, that is neoglucogenesis. Again that glucose will help you a lot. That is how Pottu Sriramulu lived for about 41 days. Okay, that is a true satyagraha at those times. So what are all the excess glycogen is there in the muscle and liver? Exhausted for few hours, and after that what are the amount of the protein and the fat cells is there in their body, making converting to the glucose. So meanwhile they also get the ketone bodies. So starvation ketosis, and this starvation ketosis they are going to die if they live for a longer period with the ketosis. So obviously the dehydration, okay, and electrolyte imbalances, and then cardiac arrhythmias, and then the death. So this is the insulin. So insulin action in the liver stimulates the glycogen synthesis, then the inhibits the glycogenolysis not to get the more and more glucose, again inhibits the neoglucogenesis, thereby it reduces the hepatic glucose output. Suppose what happens when there is no insulin? So reverse. In type 1 diabetes, what happens? Stimulates glycogenolysis. So what are all the glycogen is there in their body, that will be converted. Then stimulates neoglucogenesis. So what happens to their body weight in type 1 diabetes? Why it decreases? Because of the protein loss. Why protein loss? Because of the neoglucogenesis. So to survive the body. Okay. So then what happens to their hepatic glucose output? Insulin inhibits. Insulin deficiency increases. So what happens to your blood sugars? So what happens to blood sugars in type 1 diabetes? Are they low or high? So this is all because of the insulin deficiency. Am I clear? So on the adipose tissue, increases the availability of the free fatty acids and glycerol by stimulating the lipoprotein lipase. Stimulates lipogenesis. So what happens when you are giving the insulin to the individual? Are they gaining weight or losing weight after insulin therapy? So lipogenesis or lipolysis? Lipogenesis. So inhibits lipolysis by inhibiting the hormone sensitive lipase. So the main defects of the type 2 diabetes. So this is the 3 hyperglycemias. So one is impaired insulin secretion. So see what is the diagram? Pancreas. Head of the pancreas, body of the pancreas and tail of the pancreas. Okay. So what is this diagram here? Liver. So that is increased hepatic glucose production. So what is the diagnosis there? That is decreased glucose uptake. Okay. So one is the pancreas, then the liver, and then the muscle or the adipose tissue. So these are the important organs to cause the insulin. Earlier we thought that this is the triad. Now tell me how many ways of getting hyperglycemia? Omnious octet. Okay, omnious octet means 8 ways of getting hyperglycemia. Now we have 12 causes of hyperglycemia. These are the 3 main causes. One is the pancreas, you blame it. You blame the liver. You blame the muscle. Okay, so these are the 3 ways of getting the hyperglycemia. Later that, omnious octet. See, this is the development and the progression of the type 2 diabetes. See, is the diabetes is an aggressive and progressive? Yes or no? Diabetes is an aggressive disease, a progressive disease, and a dynamic disease. The approach in diabetes is always aggressive, progressive, and a dynamic. Now, see here. So first, what happens with the 100? See, a yellow beta cell function. So on the day 1, we are having 100% of the beta cell function. Do you get the diabetes? No. Then only you get the diabetes. So once the 10% of the beta cell loss, there will be hyperinsulinemia. So more and more insulin cells will be secreting. So that is the beta cell function. And then your insulin resistance. So insulin resistance is a progressive one. Whereas the beta cell function is decreasing gradually and insulin resistance is increasing gradually. A stage will come where insulin resistance gives way to the beta cell function and then gives diabetes. So insulin resistance and beta cell defect will cause the diabetes. What is insulin resistance? At the state in which normal amount of insulin produces a subnormal response. Not 100 units, 200 units, 300 units. Earlier, when an undergraduate, insulin resistance means more than 100 units of the insulin therapy causing hyperglycemia, or more than 200 units of the insulin. Still, patient is having hyperglycemia, that is insulin resistance. But now the definition of hypertension, insulin resistance is normal amount of the insulin produces a subnormal response. So these are the sites. Major sites of the insulin resistance, 3 sites. One is the liver, second one is adipose tissue, third one is the muscle. Liver, muscle and adipose tissue. See the insulin resistance in the liver. So what happens? Accelerated neoglucogenesis, accelerated glycogenolysis, increased hepatic glucose output, and increased synthesis and secretion of the triglycerides, rich VLDL. So more triglycerides. Okay. So that is the reason in uncontrolled type 2 diabetes, you will have more triglycerides. So dyslipidemia is also very common. Skeletal muscle. Reduces glycogen synthesis, reduced uptake of the glucose after a meal, so the blood glucose will go up, increase the deposition of the triglycerides. Adipose tissue, increase the lipolysis and release of the free fatty acids. So more ketosis. So that's how the diabetic ketosis occurs in type 2 diabetes. More and more insulin resistance means more lipolysis and more ketone bodies formation. Abnormal balance of the adipocytokines. Reduced adiponectin levels. These adiponectin levels I told you. high levels of the leptin, resistin and tumor necrosis factor alpha. What are the conditions producing insulin resistance? Puberty, pregnancy, now obesity, overweight and obesity, and Cushing's, acromegaly and steroids. So all these will cause. So nowadays insulin resistance causes mostly your body weight, your overweight and obesity, and then steroid. Steroid therapy is also very high in some individuals. First phase, second phase, third phase. Clinical correlates of the insulin resistance. So by seeing the patient, we should say that this fellow is having insulin resistance. So overweight or obesity, obviously more insulin resistance. Polycystic ovarian syndrome, very common in our, very common ultrasound finding nowadays is fatty liver and PCOD. Non-alcoholic fatty liver disease, that is your fatty liver. Diabetes or dyslipidemia, more blood sugars, skin changes, acanthosis nigricans skin tags, presence of hypertension, presence of dyslipidemia, presence of hyperuricemia. So these are all correlates of insulin resistance. So earlier uric acid means only gouty arthritis. Now uric acid means hyperuricemia, means more and more metabolic syndrome also. More obesity, more metabolic syndrome, more uric acid levels. See the beautiful acanthosis nigricans and the skin tags appearing. How to measure the insulin resistance? The gold standard is HOMA, homeostasis model assessment or quickie. So this is how they get the values. Defects in the beta cell function in the type 2 diabetes. Okay. See the normal and the type 2 diabetes. So I told you the first phase of the insulin release will be there in the normal individuals. What happens in the type 2 diabetes? Is the first phase is there? No. The red one is the diabetes. So that is the reason you are having postprandial hyperglycemia. Defects in the beta cells will be there. There is a glucose toxicity and lipotoxicity. What you mean by the glucose toxicity? Fasting blood sugar more than 250, postprandial blood sugar more than 350, you consider as the glucose toxicity. What is the antidote to the glucose toxicity? Toxicology. What is the antidote of organophosphorus poisoning? Atropine is the right answer, not the palm. Okay, atropine is the antidote of organophosphorus poisoning. What is in the same way, what is the antidote for your glucose toxicity? Starts with letter I. No OHS. Okay, when the fellow is having the toxicity, glucose toxicity, what is the antidote? Start insulin. So lipotoxicity. So more lipids. What is the antidote? Statins. So this is a very good. Which comes first? Egg or chicken? Insulin resistance or insulin deficiency? It's very difficult to say. Okay? Very difficult to say. Other hormonal defects, not only your beta cells, your insulin, hyperglucagonemia, incretin hormones, GLP-1. So these are also other hormones. This is the omnious octet. Okay. So the first one is your beta cells, then the intestines, then the adipose tissue, then the kidneys, then the muscle, then the brain, then the liver, and then the alpha cells. So these are the 8 ways of getting the hyperglycemia, and we have the drugs to act in the different ways. I will tell you the same picture when I tell you the drugs which act. Suppose you are using SGLT inhibitors, where they act? Only on the kidneys. Suppose if you are using the metformin, where they act? To reduce the insulin resistance. Okay, insulin resistance means 3 areas: liver, muscle, adipose tissue. Suppose you are using pioglitazone. Pioglitazone again reduces the insulin resistance. Where? Again liver, muscle, adipose tissue. Suppose you take the metformin, 80% at the liver, 20% at the muscle and adipose tissue. Suppose you are using the pioglitazone, maybe 60% in the muscle and another 40% at the liver and adipose tissue. Okay. Suppose you are using the sulfonylureas, your glimepiride, where they act? Your glimepiride or glibenclamide or your glipizide, sulfonylureas. Sulfonylureas, where they act? Are they act at the kidneys? Are they act at the liver? They stimulate beta cells. Pancreas. So obviously pancreas. So all these things I will tell you when we will go into the drug therapy. So genes are very important. We can't change our parents. So genetical diseases are there. So type 2 diabetes is also a big genetic disease. So runs in the families. So as we can't change our parents, if both our parents are having the diabetes, we are likely to have the diabetes. If the single mother is having the diabetes, 42% of chances of getting the type 2 diabetes in you. If your father is a diabetic, there is a 30 to 35% chances of having the diabetes. If the both parents are having the diabetes, 65 to 70% of you people are having the diabetes. No family history of the diabetes, still 25% chances of are there because you are an Indian. So Indians and Southeast Asians are at high risk of getting the type 2 diabetes. So with mother 40%, with father 30 to 35%, both about 65 to 70%, no family history, still 25% chance are there because of your Indian origin. So there are several environmental factors are there. You are all know the environmental factors. First and foremost is the sedentary lifestyle. How many of are you making 10,000 steps a day? Raise your hands. 10,000 steps a day. So must 10,000 steps a day. So otherwise you are all sedentary. Sedentary means more insulin resistance. More insulin resistance means future diabetes. You may be pre-diabetic right now, but definitely you are a diabetic in the future. So consumption of the diets high in the fat and the calories. All the street foods, dense calories. Cheapest food, dense calories. Your 100 rupees biryani, very, very high, dense in calories. Okay. Lack of physical activity. So that is very common because of industrialization and our motorization. Psychosocial factors. Stress, depression. Both will cause more and more food intake. And then your good hormones will reduce in its strength and your bad hormones will produce in a high level, your steroids, your cortisol, etc. And again they cause counter-regulatory hormones, cause hepatic glucose output and then hyperglycemia. So all these are the risk factors for the diabetes. All of you are having these risk factors. You are all having the physical inactivity, you are having the sedentary lifestyle, you are having the more diets, and also psychosocial factors are very, very high in our profession. So stress, so strain, deprivation, etc., very high. So this is the gene and environmental interaction, metabolic abnormalities, major metabolic defects. This is the Revan, a great fellow. Yes, these are the different names of your metabolic syndromes. Syndrome X, insulin resistance syndrome, etc. Beer belly syndrome. They consume a lot of the beer, Western population, to get more and more abdominal adiposity and insulin resistance.
Thank you.